Everybody's here. Great. Insurance will come to order. Members, I know we're running around and,
Call the roll.
oh, yeah, I'm sorry. The clerk will call the roll.
Chairman
My mistake.
Oliverson?
Here.
Vice Chair Ann Johnson?
Here.
Representative Paul?
Here.
Representative Cortez?
Here.
Representative Perez?
Here.
Representative Kane?
Here.
Representative Julie Johnson?
Here.
Representative Hull?
Here.
Representative Caroline Harris?
Present.
A quorum is present. Members, I know we all have things this afternoon, we'll be running around, so I thought we would just take this brief moment before we continue testimony on Representative Harris's bill and vote out some bills so that we can get that off of our agenda to do today. So, be that the case, yes? Okay, so the chair lays out House Bill 1039 as pending business. Members, you may recall this is Representative Ed Thompson's bill regarding ALE, alternative living expense. The chair lays out a committee substitute. The committee substitute clarifies that the covered loss must occur at the property. And what does that say?
It says, is there objection to the
Oh, occurs at the property. Is there objection to the adoption of the committee substitute? Hearing none, the substitute is adopted. The chair moves that House Bill 1039, as substituted, be favorably reported to the full House with the recommendation that it do pass and be printed and sent to the Committee on Local and Consent Calendars. The clerk will call the roll.
Chair Oliverson?
Aye.
Vice Chair Ann Johnson?
Yes.
Representative Paul?
Aye.
Representative Cortez?
Yes.
Representative Perez?
Aye.
Representative Kane?
Aye.
Representative Julie Johnson?
Aye.
Representative Hull?
Aye.
Representative Caroline Harris?
Aye.
There being 9 ayes and 0 nays, the motion prevails. The chair lays out House Bill 1554 as a matter of pending business. Members, this is Representative Raymond's bill requiring a life insurance company to disclose the beneficiary of a life insurance policy to the funeral director on the director's request and with written consent of the heir's representative, or the decedent's personal representative. The chair moves that House Bill 1554 without amendment be reported favorably to the full House with a recommendation that it do pass and be printed. The clerk will call the roll.
Chair Oliverson?
Aye.
Vice Chair Ann Johnson?
Yes.
Representative Paul?
Aye.
Representative Cortez?
Yes.
Representative Perez?
Aye.
Representative Kane?
Nay.
That's fine.
Okay. Representative Julie Johnson?
Aye.
Representative Hull?
No.
Representative Caroline Harris?
Aye.
There being 7 ayes and 2 nays, the motion prevails. The chair lays out House Bill 1239 as pending business. Members, House Bill 1239 is my bill which seeks to prohibit insurance companies that do business in the state of Texas from using criteria such as ESG or DEI factors for the purpose of underwriting. The chair lays out a complete committee substitute. The committee substitute, members, I know it came back today, was the result of many discussions with the stakeholders and the arrival upon a language which I believe the stakeholders find to be generally very acceptable to the bill as filed. And so I think we addressed the concerns that were brought up. The other thing that I think is significant, if I remember correctly in the committee sub, is that we removed the language regarding DEI and instead decided to focus on a disparate impact analysis, which essentially is something that's already being done by or being potentially required in other states. Again, sort of the same vein, non-actuarially based, non-actuarially sound principles that would essentially undercut an insurer's ability to accurately price risk according to statistics, math, and reality. And we think it's something that is a little bit more, can put your arms around it. So is there objection to the adoption of the committee substitute? The chair hears none and the substitute is adopted. The chair moves that House Bill 1239 as substituted be reported favorably to the full House with the recommendation that do pass and be printed. The clerk will call the roll.
Chair Oliverson?
Aye.
Vice Chair Ann Johnson?
No.
Representative Paul?
Aye.
Representative Cortez?
Yes.
Representative Perez?
No.
Representative Kane,
Aye.
Representative Julie Johnson,
No.
Representative Hull,
Aye.
Representative Caroline Harris.
There being 6 ayes and 3 nays, the motion prevails. The chair lays out House Bill 2839 as pending business. Members, House Bill 2839 is Representative Smithy's bill, which is a TDI biennial recommendation which grants rulemaking authority to the TDI Commissioner to adopt a liquidity stress test framework, including scope criteria and reporting templates. The chair moves that House Bill 2839 without amendment be reported favorably to the full House with the recommendation that it do pass and be printed. The clerk will call the roll.
Chair Oliverson.
Aye.
Vice Chair Ann Johnson.
Yes.
Representative Paul.
Aye.
Representative Cortez.
Yes.
Representative Perez.
Aye.
Representative Kane.
Aye.
Representative Julie Johnson.
Aye.
Representative Hull.
Aye.
Representative Caroline Harris.
Aye.
There being 9 ayes and 0 nays, the motion prevails. The chair lays out House Bill 109 as pending business. Members, House Bill 109 is Representative Johnson of Dallas's bill, which amends the insurance. I just like saying that.
It's a good ring to
It is, it does have a good ring to it. Which amends the insurance code to prohibit a health benefit plan that provides coverage for hearing aids from denying an enrollee's claim for a hearing aid solely on the basis that the price of the hearing aid is more than the benefit available under the health plan. This bill does not expressly mandate that a health benefit plan pay more than the enrollee's claim for a hearing aid, does not require that the health plan pay more towards the enrollee's claim than the benefit has available. So in other words, essentially the plan would be responsible for the benefit allowable amount, and if the consumer decided to select a more expensive device that was above and beyond that benefit allowable, then they would pay that out of pocket. The chair lays out a committee substitute. The committee substitute reduces redundancy by removing the mention of health benefits provided through a church benefits board defined under subchapter I, Chapter 22, Business Organizations Code. Such organizations are exempt from the insurance code, so changes made by this bill would not be applicable to them. Is there objection to the adoption of the committee sub? The chair hears none. The substitute is adopted. The chair moves that House Bill 109 as substituted be reported favorably to the full House with the recommendation that it do pass and be printed and sent to the local and consent calendar. The clerk will call the roll.
Chair Oliverson.
Aye.
Vice Chair Ann Johnson.
Yes.
Representative Paul.
Aye.
Representative Cortez.
Yes.
Representative Perez.
Aye.
Representative Kane.
Aye.
Representative Julie Johnson.
Aye.
Representative Hull.
Aye.
Representative Caroline Harris.
Aye.
There being 9 ayes and 0 nays, the motion prevails. The chair lays out House Bill 1996 as a matter of pending business. Members, this is Representative Hull's bill, which would authorize family leave insurance policies that can be used to provide fully insured paid family leave benefits for employees through optional employer-sponsored group coverage or voluntary purchased employee policies. The chair moves that House Bill 1996 without amendment be reported favorably to the full House with the recommendation that it do pass and be printed. The clerk will call the roll.
Chair Oliverson.
Aye.
Vice Chair Ann Johnson.
Yes.
Representative Paul.
Aye.
Representative Cortez.
Yes.
Representative Perez.
Aye.
Representative Kane.
Aye.
Representative Julie Johnson.
Aye.
Representative Hull.
Aye.
Representative Caroline Harris.
Aye.
There being 9 ayes and 0 nays, the motion prevails. The chair lays out House Bill 2188 as a matter of pending business. Members, you may recall that House Bill 2188 is Representative Dennis Paul's bill, which would it changes the requirement to qualify as a statistical agent and would allow it more easily for folks, additional statistical reporting agents to be considered for appointment by the Texas Insurance Commissioner. This is the one that changes the qualification of having to have 5 years experience to 2 years of experience in a particular chapter and subsection of the insurance code. The chair moves that House Bill 2188 without amendment be reported favorably to the full House with the recommendation that do pass and be printed and sent to the local and consent calendar. The clerk will call the roll.
Chair Oliverson.
Aye.
Vice Chair Ann Johnson.
Yes.
Representative Paul.
Aye.
Representative Cortez.
Yes.
Representative Perez.
Aye.
Representative Kane.
Aye.
Representative Julie Johnson.
Aye.
Representative Hull.
Aye.
Representative Caroline Harris.
Aye.
There being 9 ayes and 0 nays, the motion prevails.
We missed 1074.
Oh, I didn't have that on my list. Okay.
We're not doing that.
Oh, it is. I'm sorry. I skipped a page. I apologize, members. I missed a page. The chair lays out House Bill 1074 as a matter of pending business. Members, you may recall House Bill 1074 is Representative Hull's bill, which seeks to amend Section 543.003 of the Insurance Code to clarify that loss control and mitigation services are not deceptive trade practices, nor are they prohibited by anti-rebating and anti-inducement statutes, as long as these services are integrally related to the policy and aimed at predicting and preventing losses under the policy. The bill includes language that would prohibit unfair discrimination to ensure that similar products or offers are made to similarly insured and that products or services are reasonable in comparison to the customer's policy. The chair lays out a complete committee substitute. The committee substitute includes consumer protection language prohibiting the insurer from providing to another person any data or any other information obtained about the customer from or in connection with the loss control product or service offered. Additionally, the committee substitute includes a technical correction to add section 1806.059, which is de minimis provisional items, to the list of sections referenced in the opening clause of section 1806.002 to clarify that insurers and agents may give de minimis promotional items. Is there objection to the adoption of the committee substitute? The chair hears none and the committee substitute is adopted. The chair moves that House Bill 1074 as substitute be reported favorably to the full House with the recommendation that it do pass and be printed and sent to the local and consent calendars. Is that what you want?
Yeah.
Okay. The full House with the recommendation that it do pass and be printed and sent to the local and consent calendar. All right. The clerk will call the roll.
Chair Oliverson.
Aye.
Vice Chair Ann Johnson.
Yes.
Representative Paul.
Aye.
Representative Cortez.
Yes.
Yes. Representative Perez.
Aye.
Representative Kane.
Aye.
Representative Julie Johnson. Aye.
Aye.
Representative Hull.
Aye.
Representative Caroline Harris.
Aye.
There being 9 ayes and 0 nays, the motion prevails. Okay, we get everybody? Okay. All right.
Yeah, we're gonna wait for that one. It was 998. They were gonna add the, you said we weren't ready for that.
Oh, okay.
Fair play bill.
The fair bill where we want to dismantle.
Oh. Okay, so we don't,
We don't have to.
We never
decide
vote
for
on
that. No, we do, but we don't, we can do it if we want, but.
we have a substitute or whatever.
Yeah,
we're voting on?
I just,
Is there a substitute?
no, let me check. Yeah, we have a substitute, but it wasn't what we talked about. No.
We can do it next week.
This conversation.
No, you were expanding it to cover communities with more than 2 million people. Remember?
Yeah, has that been changed?
No.
Oh, okay. But he wants, he's gonna vote it out anyway.
Well,
We
you
can
can
do it next week. We can do it next week.
What do you want to do?
Is it ready to go? Yeah.
I think there's a question about whether it was gonna be bracketed to counties more than 2 million.
Oh, well, I don't think it needs to be. If you got grief, we can talk about it.
Well, we did get some grief on it, but that's.
All right,
it's
let's
up to you.
talk
If you don't
afterwards.
wanna make the change,
No, nobody's told me anything about that. We can bring it up later.
all right, we'll do the first thing we vote out next time, or we can do it in a formal later this week.
Yeah, okay. Let me find out about that and we'll see if we can do that.
Okay. Members, we're gonna move on. And so at this time, the chair lays out as a matter of pending business, House Bill 3351. This bill is, she doesn't need to lay it out again
No.
because she's already done that. We're just gonna continue on with testimony. Yes?
Yes.
All right, perfect. At this time, The chair calls
Charles Miller.
Mr. Charles Miller.
Good afternoon. Charles Miller on behalf of Texas 2036 here testifying for the bill. Thank you, Representative Harris, for bringing this bill. A number of previous witnesses have discussed the importance of the need for enrollees and patients to have increased quality information so that they can make important decisions about value in healthcare.
Charles, I'm sorry. Can you start over and just name who you represent, position on the bill?
Sure,
so
sorry.
we can get our record straight.
Charles Miller on behalf of Texas 2036 here for the bill.
Thank you, sir.
So as I was saying, I think that the position that we need to have quality information to help people make value decisions is important. And I think this is especially important as price transparency has taken root. Starting January 1 of this year, enrollees for insurance plans started getting provider-specific price information. And absent quality information, we fear that there may be a race to the bottom on price without regard to quality. We understand that there are certain concerns about making sure that medical providers have fair notice of the quality rankings that would be used to evaluate them. Certainly, we are in favor of that being publicly released prior to those rankings being issued. With regard to there being a chance to I would say, send a complaint about how that is being done. I think that there was a model that was proposed earlier or referenced earlier by one of the witnesses that makes sense. And this is the way that consumers interact with credit bureaus, and that you do have a right to challenge information that a credit bureau has that is incorrect. So if one of these quality rankings had incorrect information about you, there would be a vehicle for you to challenge that, but that there would not be this generalized individualized process that would prohibit the use of any quality ranking being out there before all of these issues were resolved. That existing due process standard in the bill is overbroad and has effectively prevented any of these rankings being out there. So we support this conceptually, look forward to working with stakeholders to find an acceptable resolution, but do believe very strongly that quality is an important component of determining value.
Thank you, Charles. Members, any questions? Representative Harris?
I just want to say thank you for being here and thank you for testifying.
Thanks for bringing this bill.
For the bill.
Yeah, I do think this is an incredibly important thing that we're working on. And I feel like this is, literally one of the most important legs in the stool, if you will, as far as helping patients be better consumers. And I heard you testify about this, so I just want to make sure we have your commitment. I mean, this is one of those things that has to be done right the first time. Otherwise, it'll be a dumpster fire, and it will cause untold harm. So it's like I want to make sure that you're committed to this process. That we want to find these best practices, these things that are measurable, that are quantifiable, and that are meaningful in terms of separating different levels of quality. Because I think that's sort of the rub, right? Is you can come up with a bazillion criteria, but do they meet those characteristics?
I agree absolutely with that. I would say that one caution on this, and that is that anytime you try to derive consensus about the exact quality measures to be used, you're going to have disagreement.
Fair point.
To some extent, quality is a subjective measure, and it's okay if there are differing standards. I think the important thing from our perspective would be that the entities propagating them are unbiased and have the right intent to use them properly.
Yep, totally agree with you, and I'm just glad you're part of that process.
Happy to be a part. Thank you.
Appreciate it, Charles. The chair calls, who else do we got here?
Tom Denniston.
Mr. Tom Denniston.
Hello, good afternoon. I am Tom Farrell Denniston, representing Denniston Data, and I'm here to speak in support of House Bill 3351. Thank you for the opportunity to speak about this bill. The co-founders of Denniston Data have been involved in healthcare for over 30 years. Their work is typically focused around medical efficacy and price transparency. For example, their previous company advanced evidence-based medicine through the creation of the workers' compensation treatment guidelines that Texas and now most of the United States uses. Regardless of the task, one goal remains the same: to always focus on improving the quality of care that patients receive. As you well know, almost 20% of the United States gross domestic product, roughly $4 trillion, is spent on healthcare. The number is rising, and we need services and processes that can improve efficiency and effectiveness. In 2010, the Institute of Medicine issued a report stating that waste accounted for 30% of healthcare spending in the U.S., approximately $750 billion a year. This quote unquote waste was more than our nation's entire budget for K-12 education. The report found that higher prices, administrative expenses, and fraud accounted for almost half of the waste. Bigger than any of those, however, was the amount spent on unnecessary healthcare services. Just like treatment guidelines, we need a way to evaluate healthcare objectively and with a lack of bias, including a way to evaluate medical providers. PubMed says that over 20% of overall medical care is unnecessary or harmful. Studies show that experienced doctors do not incur the excess costs associated with inappropriate care. This is an area where Denison Data has been focused for the last several years, ranking medical providers based on actual evidence of their experience by procedures performed. Studies have shown when we assist in sending patients to the best providers for what they need, we get the best outcomes. Adding in price transparency also helps consumers make the best decisions for their health. When quality of care, cost transparency, and patient access to this information all come to light, costs do invariably go down. The work you are all doing with the All-Payer Claims Database, and hopefully now with House Bill 3351, will begin to move the needle to achieve affordability, efficiency, and transparency. Thank you, and I'm happy to receive any questions that you have.
Thank you, Mr. Denniston. So your company obviously has some experience in this. So could you talk about like what makes a good quality criteria from your perspective as somebody that does data for a living? What are we looking for here when we're looking for, you said objective, verifiable? How do we find those things?
Well, so what we did, thank you for the question. For what we did for our provider ranking system, we made it as objective as possible, just like in the previous company with official disability guidelines. That's evidence-based medicine, nothing subjective, and same thing with provider ranking system. It's just data. It's objective data. So currently we have over 1 million providers ranked, and how we rank them, we cannot say they were polite or that they the outcomes of every patient or anything like that, because it's just not possible for us to do that anyway. So we use data. We use Medicare data on how often each provider is doing each procedure per year of their specialty compared to their peers of their specialty. So we rank them in that sense. So it's a ranking, not necessarily we know this doctor performed this process or this procedure the best, but this doctor or this medical provider is doing this particular procedure more often than any other provider, or not, more or less often, depending on what their ranking is. How do they rank out of that pool of providers in their ZIP 3 and nationally? We give them a local and national ranking. Who is doing it the most? Who's doing it the second most, third most, so much, all the way down to the bottom. So you can see, because studies have shown, and we have them on our website, denisondata.com, on our kind of marketing website, lots of studies that show that experienced medical providers lead to good outcomes. It leads to a procedure being done correctly, and also avoiding an inappropriate procedure being done, and leads to a recovery of the patient and them back to full health, which is the goal. And also what's interesting, if you look at our data and the provider ranking system, so these number 1 through, whatever, let's say 1 through 10 providers, you think, oh, well, they must be the most expensive. No, they're not. Actually, on our column charts, you can organize them by column. They're all dynamic columns. You can order them any which way, filter them however you want. The highest ranked ones are not the most expensive. If you order it in the most expensive charges by provider, those are people sometimes not even in the top 25 or top 50%. So
okay, so I just want to drill in on your example, because I want to make sure I understand this correctly. So are you saying that a measure of quality would be the number of times that a provider performs a particular procedure? In other words, the idea that, experience leads to better outcomes?
Yes, that's correct. So practice makes perfect, right?
Which totally makes sense in the case of a procedure, but how would you apply that to I don't know, somebody being admitted to the hospital or somebody getting a prescription for a medication or something. I guess what I'm trying to, I mean, I've spent a lot of time thinking about this, and I think there are significant limitations to just sort of the one-size-fits-all approach to quality because healthcare is so individualized. And complexities arise, right? Not all patient populations are created equally. And so somebody can very easily be in a private practice where everybody is completely healthy, no comorbid conditions or whatever, and so their outcomes look phenomenal compared to somebody who's practicing in a charity clinic where they're seeing people that literally don't have access to primary care and have many comorbidities. Those doctors may look very different, but essentially it could be the doctor in the community clinic that's actually the higher quality.
No, that's a great point. And we also have rankings locally. So ZIP3, the first 3 digits of a zip code. In addition to that, besides telling the credentials, where they went to school, what year they graduated, we tell you patient demographics. So who are they seeing and what risk level of their patients? So anything above 1.5 would be of high risk. 1.0 would be average. And we tell you an exact numeral down to the decimal of the risk level of the patients that provider sees. We also tell you lots of other little facts about that you can take into account. Now, granted, it might be a piece of the pie, or whatever the expression would be, but it's or a leg to the stool, maybe I should say. But it's an important leg to know the experience, the credentials of the provider, the experience of the provider. Are these providers operating on similar patients in a similar location, or other things like that? Risk level of patients. So if the provider is only seeing average and below average risk patients, well, it's no wonder that they have a good.
I just think that's an important consideration, because when I talk to providers about this, the biggest pushback I always get from my colleagues is, well, no two patients are created equal. And it's very easy for me to be in a practice where it looks like I'm providing exceptional quality when really it has everything to do with the general health of my patient population.
That's fair, and we're not saying that that's not. We're not saying that that's not important, but that also doesn't.
But can you account for that, is what I'm asking?
Well, what we are not doing, we are not telling you patient outcomes because we do not know. But we also know if a medical procedure should only be done once, and a doctor tends to do it or as a repeat pretty often, that's not a good sign.
Clearly.
So,
these are all good questions to be asking, and I appreciate you being part of this conversation. Members, are there any questions for Mr. Denniston? Sir, thank you very much for your testimony today.
thank you very much for your time.
The chair calls Ms. Shannon Maroney.
Good afternoon, Mr. Chairman and members. I'm Shannon Maroney. I'm here on behalf of the Texas Association of Health Underwriters in support of House Bill 3351. We are an association of around 1,300 health insurance brokers and agents across the state. And after we sell these policies and help our customers find a policy that will work for their budget and their employees, we also service the policy.
Hey, sorry, Shannon.
Sorry.
I apologize. You registered under your new
Oh, sorry.
thing, and
Okay.
so you're not Tahoe anymore.
We're not Tahoe anymore.
I have you registered as the National Association of Benefits and Insurance Professionals, NABIP-Texas.
Correct, NABIP, Texas.
And you are
Sorry.
testifying on behalf of that organization.
Yes, I am. Sorry about that.
And you're
Same
for the
organization. Yeah,
Okay.
for the bill, support of the bill. And our 1,300 agents and brokers, when we sell health insurance policies to employers and their employees, we service those policies as well. So we get a lot of questions in the life of those policies. And one of the most common one we get is, how do I pick from one of these providers when I need a new doctor? Because as this committee knows, you guys have done a ton of good work on transparency around directories and making that information available, making sure it's available. But what's still lacking from those directories is any information about cost, quality, effectiveness of the physicians. The health plans have enormous amounts of data on all of that, as you know. And in all other ways, we're passing legislation and driving people to use those directories. So in our opinion, this is really overdue because the health plans are not able to put any of that information out to their members, even though they are required to put a lot of other information out to the members. And quite frankly, I think if I were a physician, I think I would be clamoring for this legislation because in the age of, the statute was originally written in 2009. It's hard to believe that Google and Yelp were not really a big thing at that time, or at least Google reviews, but they weren't. And now they are. And so your example, Mr. Chairman, earlier of how hard it is to get a bad Yelp review removed when it has no basis. In fact, it's just somebody who's angry about who knows why, is a great example. That's what we're left with right now. And really, this would still have a lot of very important guidelines, safety things in place that would still be in place and would at least give the physicians some safeguard around those types of things. And we don't have any of that on Yelp or Google. There's all these other websites, ratemds.com, vitals.com, healthgrades.com. Most of them are paid. So that's, so that's really the only thing that you have to do to get a review on there is pay for it. So from a consumer perspective, and that's always our, who we're looking out for, this would be so much better than just the Wild Wild West, which is what's going on right now. So we support the bill. We think it's strongly needed. We thank Representative Harris for filing it, and we're here to answer any other questions you might have.
Thank you, Shannon. Appreciate it. Did you have a question, Representative Harris?
First of all, thank you.
Thank you.
Good to see you. And I just wanted to point out that in the bill, we do not strike the two requirements that say physicians currently in clinical practice have to be actively involved in the development of the standards used in the chapter. So that's still a pretty good safeguard. And then secondly, measures and methodology used in the comparison programs have to be transparent and valid. So we're going to work on some language, I know, but I just want to point out that there's still some kind of safe measures that we're not taking out.
Right. And I know from my experiences in another life of working for a health plan, I know what they are doing behind the scenes to make sure that the data is valid and that it's evidence-based and that it's grading, like versus like, comparing specialties to their same specialties. So you're not seeing, the problem you're talking about earlier about your patient population making a big difference. It definitely does. So anyway, we just really encourage the committee to support the legislation.
Absolutely. Shannon, thank you for being here today.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 3351? Seeing none, the chair recognizes Representative Harris to close on her bill.
Thank you. I just want to close with a couple of stats, and I think that we've got a lot of good discussion. I think we can come to a really good place on this bill. But I just wanted to remind the committee and those here that a couple years ago, there were studies that showed that medical error was the third leading cause of death in the U.S. This was based on research and studies. And I'll point out that that is not put on death certificates. There's medical error is just not included. And so a lot of the reporting on top causes of death don't include medical error for that reason. And so I just want to point that out, that we're trying to, make sure we come to a good compromise on this bill and make sure that we're getting patients quality data along with all of the price transparency data that we've been asking everybody to provide lately. So with that, I want to get the language right. Thank you, Mr. Chairman and members. I would appreciate the committee's favorable consideration. And with that, I close.
Thank you. Thank you, Representative Harris. I just want to say thank you for taking this issue on. This is a big one. It's not an easy, quick one, but I know you're up to the task, and I look forward to helping you in any way that you need so that we can get this done. Thank you. Members, are there any other questions for Representative Harris? If there's no objection, House Bill 3351 will be left pending. Is there objection? The chair hears none. House Bill 3351 will be left pending. At this time, the chair lays out House Bill 1322. The chair lays out a complete committee substitute. The chair recognizes Chairman Buckley to explain his bill.
Thank you, Chairman Oliverson, members of the committee for hearing this bill. I want to thank all the stakeholders that have gotten together to work on the language for the important committee substitute. This bill is about establishing a mechanism for a patient to have their health insurance plan and their vision benefit plan coordinated when both plans cover eye care services. When a patient has both types of plans, allowing those plans to be coordinated saves the patient out-of-pocket expenses, and unnecessary visits to the doctor. There's already a statute pertaining to coordination of benefits, but those statutes are about medical plan to medical plan coordination and dental plan to dental plan coordination. HB 1322 would resolve that. This bill would create an opportunity for patients to have their medical plan and their vision plan coordinated for eye care services, only up to the coverage limits of each plan. The bill has gone through several revisions, and we've worked on this substitute language with feedback from the health plans, from vision plans, and from the Texas Department of Insurance. We made sure that the bill language works within the standard coordination rules that already exist and are already on the books with TDI. I know that there are practicing optometrists who will be testifying today about how coordination of benefits will benefit their patients. And with that, I'm available for your questions. I thank you for your consideration, and I reserve my right to close.
Thank you, Chairman. Members, any questions for Chairman Buckley? All right, we reserve your right to close. Looks like we have one witness for this bill, so don't go too far. The chair calls Mr. Tommy Lucas, Dr. Tommy Lucas. Sorry, Tommy.
That's right. Hey, good afternoon, Chairman Oliverson and committee members. My name is Dr. Tommy Lucas. I'm representing myself as an optometrist and also the Texas Optometric Association. I'm testifying in support of House Bill 1322, and I want to thank Chairman Buckley for bringing this important bill. This bill is simply a bill that will allow a patient's medical plan and a vision plan to be coordinated together when a patient has covered eye care services under both plans. Coordination of benefits is a well-known and well-established concept in healthcare, and national and state rules are already created around this topic. So as Representative Buckley mentioned, Texas statute already exists to coordinate medical to medical, dental to dental, but there is no medical to vision statute that applies. So that's what this bill would do. We've worked directly with TDI and the health plans and vision plans to make this committee substitute conform. I think there will be one more substitute that comes with a small tweak for one of the stakeholders. And I believe after that, we'll have an agreed to bill on this particular situation. So, but thank you, and I'm available to answer any questions that you have.
Members, any questions for Dr. Lucas? Tommy, thank you for being here today.
Thank you.
Appreciate your testimony. Is there anyone else wishing to testify on, for, or against House Bill 1322? If not, the chair recognizes Chairman Buckley to close on his bill.
Thank you, Chairman. Members, thank you for the opportunity to lay out this important legislation, and I ask for your favorable consideration with this bill, and with that, I close.
The chair withdraws the committee substitute. If there is no objection, House Bill 1322 will be left pending. Is there objection? The chair hears none. House Bill 1322 will be left pending. The chair lays out House Bill 1696. The chair lays out a complete committee substitute, and the chair recognizes Chairman Buckley to explain his bill.
Thank you, Chairman Oliverson, members of the committee for hearing this bill. The committee substitute for House Bill 1696 seeks to ensure that Texans will continue to have access to high-quality eye care and that independent optometry practices will continue to exist in our communities. This bill addresses some pretty big problems that the optometrists are having with insurance companies. What I've come to find out is that the eye care industry is being heavily consolidated and vertically integrated. That's impacting how optometrists deliver care to patients. It was news to me that vision plan companies that sell an insurance benefit plan also own labs where glasses are made, frame companies that make glasses frames, and retail optical chain stores. In some cases, they're buying the optometrist office itself. It's one thing to buy up pieces of the eye care industry, but it's another thing to use an insurance product to steer patients away from some doctors and towards other doctors for the financial gain of the insurance company, and that's what's happening here. Patients deserve transparency and choice. We all know real competition drives down prices, and the lack of competition does exactly the opposite. Existing state law requires an insurer not to differentiate between services provided by a healthcare practitioner. Unfortunately, there are several plans that are violating this law. This bill seeks to provide further clarification of this law so that it is no longer abused. I brought this bill because I want the people in my district to continue to have good quality eye care and to establish some guardrails against anti-competitive and controlling behavior by some vision plan companies. This will benefit the consumer, which in this case is a patient who has an important relationship with their eye doctor. My office has worked with the optometrist and the plans on this bill this session. I believe that the substitute before you addresses some of the concerns of the insurance plans. I know there are practicing optometrists who will be testifying today that can give you firsthand examples of how vision plans attempt to control their practices and discuss how it affects the relationship with their patients. And with that, I'm available for questions, and I thank you for your consideration. Now I reserve my right to close.
Members, any questions for Chairman Buckley? We'll reserve your right to close. At this time, the chair calls Dr. Jennifer Deakins. Sorry about that, Doctor. My words tripped up a little bit there.
All right. Thank you, Chair and members. I'm Jennifer Deakins, representing the Texas Optometric Association and myself, and I'm for the bill. I am currently the president of the Texas Optometric Association, and I represent over 4,700 licensed optometrists in the state who provide millions of Texans with their essential eye care. By day, I'm clinical faculty at University of Houston at one of their community clinics, but my views here today do not represent the university's views. This bill addresses major issues with managed care plans in eye care, and it's especially focused on vision plans. These vision plans are attempting to control the practice of optometry. Corporate profits and interests are being placed before the doctor-patient relationship, which is dangerous. This bill attempts to ensure transparency and choice for patients, as Chairman Buckley mentioned, while the industry is consolidating and vertically integrating. The bill ensures safeguards and fair business practices by managed care plans so independent optometry practices can serve Texas patients and survive in this state. I'm happy to take questions.
Thank you, Doctor. Members, any questions? Doctor, I have one question for you. Why does this bill have ophthalmologists in it? Aren't those services normally paid for by medical insurance and not vision plans? I mean, unless they're actually doing a prescription for glasses.
Sure.
And I think about
Yeah.
Okay, scope of practice conversation coming up.
Yeah.
Right, but typically, when we talk about surgery, we talk about, obviously, we have co-management of glaucoma and stuff like that, but there's certain things that ophthalmologists do that really aren't anywhere close to the scope of practice for optometrists, and none of those services are actually covered by vision plans anyway.
Correct. So optometrists operate and serve patients under both their medical plan benefits and vision plan benefits. I would say typically ophthalmology serves more under the medical plan benefit. I know of maybe one or two that operate in the vision care plan space, but it's very rare. When we drafted the bill with the chairman, we simply used what was in the current section of the code and kept that consistent. As of moments ago, we've been working with the stakeholders and happy to talk to ophthalmology and the other organizations about the appropriateness of that.
So you know where I'm going with this conversation. All right.
Happy to talk.
I would encourage you, if possible, if they don't need to be in the bill and it sort of simplifies the process for you, then my strong recommendation would be to take them out of the bill.
Yes, sir. We will definitely talk to them. Thanks.
Thank you. Members, any other questions? Okay.
Thank you.
The chair calls Jennifer Cawley. Jennifer Cawley. She's not here. Okay. Well. Looks like Jay wants to testify.
Okay.
The chair calls Mr. Jay Thompson.
Mr. Chairman, members, my name is Jay Thompson. I represent the Texas Association of Life and Health Insurers. Representative Buckley, my client Jennifer Cawley, we sent a letter to your office on a very narrow area of this bill that we're concerned about, and that's the enforcement provision that's on page 12 in the new section 1451-158.
Jay, I apologize. Your position on the bill?
Our position is opposed at this point.
Thank you.
And it's really solely on that one provision. We would be on the bill. We have other members that do provide vision care to optometrists. I've seen the language that they've offered, certainly in support of their efforts, and appreciate the cooperation of the chairman and the optometrist on that. The provision we object to is using Chapter 541 to enforce this bill. That's a chapter of the insurance code that defines unfair trade practices and allows private causes of action, including attorney's fees and treble damages. Chapter 1451 is a chapter of the insurance code that deals with a number of providers, whether it's a podiatrist, optometrist, dentist, And none of those enforcement provisions in those chapters reference 541. They all, if they have an enforcement provision, it allows a company that violates it to be fined by the Department of Insurance. And that would give a very consistent, more application than private causes of action in numerous counties of this state. So I can provide language to you, Chairman Buckley, of enforcement language. We're not seeking to avoid enforcement, but do usually object to provisions that use 541. So I appreciate your consideration of that.
Thank you, Jay. Appreciate your testimony. Members, any questions for Mr. Thompson? No? Jay, thank you for being here today. Appreciate your testimony. At this time, the chair calls Dr. Tommy Lucas.
Hello again. Thank you, Chairman Alverson and committee members. Again, my name is Dr. Tommy Lucas, and I'm representing myself as an optometrist and the TOA, and testifying in support of House Bill 1696. And again, thank you to Chairman Buckley for bringing this bill. So I'd like to give a little bit of history about this issue of control of optometry. When I started practice in 2006, health insurance companies were health insurance companies and vision plans were vision plans. But today that's no longer the case. These companies are vertically and horizontally integrated conglomerates, and when we talk about vision plans specifically, they're seeking to control every aspect of the eye care industry that they can. So sadly, this includes the control of optometrists ourselves and the very nature of the doctor-patient relationship. So this issue is not new to the legislature. We sounded the alarm on this growing problem in 2015, and at that time, Senator Larry Taylor and Representative Greg Bonin authored and passed SB 684. And what that bill did was broadly prohibit managed care plans from controlling or even attempting to control the practice of optometry. But unfortunately, in the 8 years since that law was passed, vision plans have not stopped in their efforts to control optometrists, and that's why this bill is necessary. So a few specific things about the bill that are included in the bill, and I've included a breakdown of the bill because there's several clauses. So. A few things. This bill will prevent vision plans from hiding out-of-network benefit information because they are hiding it to both the patient and the doctor. In the past, the doctor was able to call and verify in-network or out-of-network benefits for a patient, and they've since stopped that because they want to steer their patients to in-network providers. This bill will eliminate improper chargebacks to reimbursements. Some vision plans, not all but some, are keeping reimbursement amounts that are intended to be paid to the doctor for the cost of goods of things we provide to the patient, like glasses and lenses. This bill will prevent the steering of patients to retail offices that the vision plan owns. They are penalizing patients if they choose a different independent in-network doctor when they don't go to a location that they prefer. This bill will prevent the ranking and tiering of doctors based on how many products the doctor purchases from that insurance company that they own. And finally, this bill will prevent vision plans from requiring the doctor to send them your personal data and unrelated medical information in order to file a claim because they want that data to help them to sell more of their cell phone products to you. So all of these things are bad, in our opinion, of course, and what they actually are meant to accomplish is to self-deal patients to themselves in an effort to keep all of the patient's money for that defined benefit program. So we've engaged with the health plans on this bill, and after good discussions with THAP, we've removed 2 clauses from the bill, including an any willing provider provision and a provision about prior authorization. So we're working with the plans on this. And I will close by saying that we understand that progress happens and that big businesses get bigger, but when a very large business engages in anti-competitive behavior to the detriment of small businesses, and when those small businesses are healthcare businesses, something has to be done to protect the patient. So thank you for your time, and I'm happy to answer any questions.
Thank you, Dr. Lucas. Members, any questions? Tommy, thank you for being here.
Thank you, Chairman.
Appreciate you. At this time, the chair calls Dr. Alina Scholar.
Good afternoon, everybody. Thank you, Chairman Alverson. Thank you, committee members, for having me and for allowing me to testify today. I am testifying for Texas 400 and the TMA in opposition of the bill. While we certainly do understand some of the insurance goals addressed in the bill that both physicians and optometrists face, such as the harms of vertical integration, we do find some potential problems here. The bill goes beyond the types of potential insurance reforms that we'd like to see and moves into other areas that are really concerning, such as the physician-optometrist relationship and the distinguishing between the two practitioners. For example, the bill prohibits an insurer from using a contractual fee schedule that reimburses an optometrist, therapeutic optometrist, or ophthalmologist differently based on the differences in their education and their, excuse me, it's a little cold in here, I'm shivering, and their degree held. So creating parity between the providers with vastly different levels of education, training, and experience is a really dangerous precedent to set, and it threatens the patient's safety, risks driving up the cost of care, and creates a perceptive loss of value for the patient. An eye exam performed by an optometrist has a different purpose and intent and extent than one has for an ophthalmology exam. So the two should not have pay equality in that case. The bill also prohibits managed care plans from identifying participating optometrists, therapeutic optometrists, or ophthalmologists differently from one another. This is concerning because there are differences that are important for patient care, such as the licensure and the scope of practice within each licensure. It's unclear what, quote, identifying means in this context, but its application is likely to be broadly construed and create some obfuscation about who is who. And it creates a false equivalency between non-physicians and physicians. This negatively impacts transparency in healthcare delivery and can lead to further unnecessary confusion amongst patients when they need care. So unfortunately, we are addressing this as a scope issue because it goes down that road. Further, the bill includes some new references to medical care that concern us, once again, from the perspective of blurring the lines between optometrists and ophthalmologists. And the bill is a bit of a Trojan horse for scope expansion, changing current language concerning a vision care benefit product into a, quote, medical or vision care product or service, end quote. And then it defines that product or service within the scope of optometry. So in other words, optometry may be erroneously defined then as the practice of medicine. So we need to make sure and get that cleared up. So for these reasons, we respectfully oppose 1696. But we do really appreciate the thoughtful conversations with the author and with other stakeholders, and we are committed to work together to find a solution to address our concerns. Again, thank you, Mr. Chairman and committee members, for allowing me to testify today. I'm open to any questions.
Dr. Schuller, I have a question, and obviously I received similar comments from the ophthalmologist group themselves. Does removing ophthalmologists entirely from this bill address your concerns?
I think removing ophthalmologists from the bill would address a major portion of the concern, but
And then we're not comparing,
right, then we're not comparing the two. The last point I made about the creating a new language that refers to optometrists as providing medical products, that's an issue we have with it as well. It may be construed they're practicing medicine rather than optometry.
But we do have a co-management agreement for glaucoma, right? So there are some times when they are dispensing medical products.
Yeah. So we don't want to really open that door any farther than it already is.
All right. Okay. Well, I appreciate your testimony.
Sure.
Question. Thank you. Oh, I'm sorry. Representative Kane, Chairman Kane. Sorry.
Dr. Schuller, have y'all spoken? Have y'all spoken previously to Dr. Buckley's office about this?
Yes, the TMA has, yes.
Okay. Was that this week?
Yes.
Okay, so it was yesterday?
Yes, yesterday and earlier this weekend, yes.
Okay. Thank you, ma'am. Thank you.
Thank you.
Dr. Schuller, thank you for being here today.
Thank you so much.
Appreciate your testimony. Is there anyone else wishing to testify on, for, or against House Bill 1696? If not, the chair recognizes Chairman Buckley to close on his bill.
Thank you, Mr. Chairman, members of the committee. Just to follow up on that, first of all, I appreciate the opportunity to work with all the stakeholders on this and how important it is that different professions, have agreements and understands what the law is and what and the way we need to interpret the statute. I want to bring up one point to you, just to close, that currently Medicare and Medicaid reimburse ophthalmologists and optometrists at the same rate, and they have been doing so since 1986. Current statute currently has anti-discrimination language in it, and so I think that's worth noting. And what we're simply, and also that there are commercial insurers that typically follow Medicare policies But there are some companies that are not following those policies and reimbursing optometrists less. And so what we seek to do here is to simply clarify what's already in statute and has been for since 1986. And I look forward to working with all the stakeholders to make sure we get this cleared up. And again, I thank you for hearing this bill, and I ask for your favorable consideration. And with that, I close.
All right. Members, any questions for Chairman? All right. We'll let you get back to your own committee, and I'll see you a little later this afternoon. Yes, sir. The chair withdraws the committee substitute. If there is no objection, House Bill 1696 will be left pending. Is there objection? No. Then House Bill 1696 will be left pending. Members, that concludes our testimony and our agenda for today. The Committee on Insurance stands adjourned, subject to the call of the chair.